This presentation is a case of an endoscopic anastomotic reconstruction with lumen-apposing metal stents. A brief mention on the current indications and possibilities with EUS and LAMS, which is growing. The most commonly known is that of drainage of pancreatic collections, but increasingly there is an evidence-base growing for interventions such as cholecystectomy, LAMS for EUS gallbladder drainage, facilitating ERCP in patients with previous Roux-en-Y, as well as novel considerations such as bridging benign gastrointestinal strictures and bypassing malignant gastric outlet obstruction. It is clear the scope and span of EUS and LAMS continues to grow. The case is a 42-year-old man who has had a previous Roux-en-Y gastric bypass. His complex surgical course started in 2020 when he had a laparotomy for a marginal ulcer causing perforation at the anastomotic site of his root limb, which required an omental patch. He presented 2 years later after significant NSAID consumption with abdominal pain. At the time, imaging demonstrated perforation at the gastrointestinal anastomosis. What ensued was 3 complex operations which involved formation and reversal of an ileostomy, complications due to multiple non-healing anastomotic joints and dehiscence, as well as multiple other procedures to attain clinical stability. Eventually, the out was disconnection of the gastric pouch to the bowel and enteral feeding via gastrostomy to a reconnected gastric remnant. From here, a long ICU admission was required of approximately 2 months, in which significant circulatory, ventilatory, and renal support was required. This diagram shows a simplified schema of the gastric anatomy. Seen here is an image of the patient's open anterior abdominal wound, alongside the gastrostomy and drain into the pouch. The issue with this end result, however, is the patient's desire for quality of life. He is a middle-aged man who was otherwise previously functioning well. The initial solution in this case was the use of an EUS-guided lamb stent to join the gastric pouch and remnant together. Endoscopically, we see here the gastric pouch with the drain in situ. EUS is used to find the gastric remnant and thereafter deploy an EUS-guided LAMS. This is seen here as well endoscopically. After utilizing the balloon to expand the stent to a good width, confirmation of the connection between the remnant and pouch is seen here with the gastrostomy tube seen in the distance. Following the procedure, the patient was able to tolerate a free liquids diet, however with symptoms of bloating and expectedly unable to tolerate a solids diet. The bloating sensation was presumed related to a phenomenon called sumping, in which the ingested content sits in the gastric pouch below the level of the axios, and only transiting through the opening after reaching a certain level. The patient was miserable with a constant sensation of bloating and the inability to tolerate anything outside of a very limited liquid diet. Therefore, a second procedure was pursued. In this procedure, a second lumen-apposing metal stent was deployed distal to the first. This allowed for better drainage between the pouch and remnant. This is seen here with initially progress made through the lumen-apposing metal stent from the gastric pouch into the remnant, with the pylorus visible in the distance. EUS is once again utilized for the insertion of a second stent. Subsequently, we are left with 2 lumen-apposing metal stents. The proximal one, which was inserted initially at the time of the first procedure, and the second stent, which we can see has nicely been deployed both at the proximal end, which lies in the gastric pouch, and the distal end, which now lies in the gastric remnant. With the second procedure, his sumping significantly improved, and he was able to tolerate more thicker fluids and a pureed diet. But despite this, he was insistent that he was eager to return to a more normal diet, to live in a greater sense of normality. Despite the improvements, he was still mentally and physically debilitated. Biochemically, there was still evidence of malnutrition, and therefore discussion was had in a multidisciplinary setting with careful consultation with the patient about the risks of further procedure and intervention. A plan was hatched for endoscopic dissection of the bridge between the lumen-apposing metal stents, thereby reversing the gastric bypass by anastomosing the gastric pouch to the remnant. The first part of the procedure was removal of the proximal lumen-apposing middle stent. Thereafter, there is endoscopic dissection using an ESD knife down to the second lumen-apposing middle stent. Here we can see the procedure being undertaken. Endoscopically, we start with the initial removal of the proximal stent. In this image, we can see the lumen left between the pouch and remnant. Starting from this tunnel of tissue, an ESD knife is used to dissect and transect the tissue between this lumen and the second lumen-apposing middle stent seen in the distance. The dissection plane is maintained through regular endoscopic visualization of the proximal and distal flange of the second lumen-apposing middle stent. Later on in the procedure, coagulation graspers are also utilized to attain hemostasis. As anticipated in this full-thickness dissection, there is involvement of dense fibrosis, which is prone to significant bleeding. As seen here, brisk bleeding is encountered during this dissection, requiring regular use of coagulation to attain hemostasis. As dissection continues, the second lumen-apposing middle stent comes into view. The ESD knife is utilized all the way down until the second stent comes free of the surrounding tissue. Once the surrounding tissue has been adequately dissected, graspers are utilized to remove the second lumen-apposing middle stent, thereby leaving behind a free tunnel between the gastric pouch and remnant. Endoscopic suturing clipping are thereafter utilized to close any small microperforations that may be present in the wall of this new opening. The final result, as can be appreciated here, is a widely patent connection between the remnant and pouch. The end result is simply portrayed here in this diagram. A CT with oral contrast was organized the next day, confirming the endoscopic success of this procedure through the absence of any leak. Finally, bringing it back to the patient. Through his initial operations, he had become both physiologically and psychologically debilitated. Through this process, our focus was clear: to help rehabilitate this patient and bring him back to a quality of life that would allow him to sustain and live a meaningful life. Multiple multidisciplinary meetings were required to reach these outcomes. However, the patient is in a better place because of them. Subsequently present the first case report of double lambs and endoscopic dissection to reconstruct and reverse a Roux-en-Y with no surgical alternative.